your slides on slideshow and leave it on the very first slide?
Sorry?
Put it on slideshow and leave it on the very first slide.
Okay.
Not on slideshow yet. Better please refresh.
Not on slideshow yet. It is on slideshow from my side. So what could have happened? And show. Think. So share window, pick the slide, share. Put it on a slideshow. Is it on slideshow now?
No, you're probably using the second screen. So either you disconnect the second screen, or when you share, choose the window where you see the slide in slide mode.
Okay, let me check again. Which one is second screen?
I don't think it's using a second screen. If you're having issues with this, we can share from our end.
Maybe you can share from your end if it's having an issue.
So Harry, stop sharing, keep the slide mode, stop sharing, and share again, but this time choose the windows where you can see your presentation in slide mode. So keep the slide mode. Just stop sharing.
Okay.
Okay.
I think
now
I already
share again. Click on share screen again and choose the window where you can see the PowerPoint in slide mode. So keep the slide mode before start sharing.
I think what happens is that once I do slide mode, it takes the entire screen. To even click anything.
So click escape on your keyboard. Just click ESC. Touch the ESC button on your keyboard. It's okay. I think we should check for you. We need to check.
Okay, you can share since I guess some people might. What do you think?
Dr. Henry, your slides are up. You can commence, please. Henry, can you hear me?
Yeah, I can hear you.
Yeah, your slides are up, please. You can start.
Okay, just a minute. Okay. Thank you very much. We want to welcome everyone to this second in the series of monthly webinar series of Avoxurge team from Nairobi here in Kenya. As you know, the essence of this webinar series is to create a community of practice and a platform for information sharing and experience sharing more first among the people who have been trained on Avoxurge and also to the entire responders across the region, African region. So in today's seminar, webinar, we are going to be looking at integrating mental health and psychosocial support into response to public health emergencies. And we have with me some panelists and presenters. So we are going to look at the agenda, which we are going to spend the first 5 minutes for housekeeping and opening welcome remarks, which I'm already giving. We also have opening remarks from the Emergency Preparedness and Response Team Leads, Dr. Martins Livinus. And then we now delve into the main presentation, which is on mainstreaming mental health and psychosocial support in responding to public health emergencies, which will be taken by Ms. Stella Waringi, and that will be done for 25 minutes. And then we take 10 minutes to do question and answers in case there are some questions and contributions from participants. And then we now take the closing remarks for 2 minutes. So before we start, we want to also remind you that this virtual training session adheres to the code of conduct of WHO on prevention of harassment, including sexual harassment, which we implement at all WHO events. So during the question and answer sessions, we can see the feature there. When you look at it at the tab of your the platform of your Zoom platform, you can see Q&A session. So if you have questions along the line of the presentation, you can quickly type in the questions, or you want to respond to anything that has been said. We'll look at all of them and then take them one after the other during the Q&A sessions. So in terms of, we understand there may be other people that may not understand English. We had wished that we were able to the presentation into all the other languages, but unfortunately, that we're not able to do that. So this presentation is only on English, and is being recorded for us to be able to share at the end of the day. So just being part of this training, this seminar, webinar is a kind of consent that you have agreed to be recorded. So the session materials, including session recordings, will be emailed to all the participants in the days after the seminar has been concluded. As we continue to improve on our training programs, our feedback is invaluable to us. A survey will be shared at the end of the session, and we highly encourage all participants to share their thoughts and suggestions as your input to help us to tailor future sessions to better meet your needs and expectations. So this is really very important that you share your feedbacks with us. So for now, this will be the end of the opening session. So we want to welcome Dr. Martins. He is the cluster lead of Emergency Preparedness and Response Cluster here in Kenya. So he will give us opening remarks. Dr. Martins, you're welcome.
Thank you, Dr. Harry. Good afternoon, everyone. Good morning, good evening, depending on where you're tuning in from. Welcome to today's webinar. And like Henry said, this is the second webinar in this series, which we started. We want to make it a monthly webinar, and we really appreciate the support we got from the colleagues from the hub here in Nairobi, Amarachi and Jaka, who has been very supportive of this process. Let me start again by apologizing that we have to reschedule this from the last time. We've rescheduled it due to some internet issues we had due to the things that were happening in Kenya at that time. But welcome everyone from from wherever countries you are. I learned that there are different countries that have registered for this webinar, and many are still, we were still registered in the course of the webinar. So welcome. Apologies again, we're not able to translate it like Henry have said, but we will share the we'll share the recordings after. So the idea of us doing this in Kenya is to showcase what we have done. We are not yet arrived. We're still improving. The Surge flagship is taking effect very well in Kenya, and I believe in other countries also. So we want to share what we have done. Most of our colleagues that have been trained have been involved in responding to actual emergencies here in the country and even outside the country. So like the topic he said, we're trying to say how we can mainstream mental health, and the colleague, Ms. Stella, is already ready to give it to us. I just want to welcome us and say, please, at the end of the webinar, your feedback is important to us. We're still trying to improve how we continue to effectively deploy colleagues that have been trained in this surge. And we want to also learn from other countries. If you have any feedback to give us, maybe in any way we can improve, because I know that most of us are part of the surge also in our various countries. So we want to see how we can improve the deployment, not just in Kenya, but across Africa, as we move on to continue to respond to the numerous health emergencies that are bedeviling Africa. So I will stop there. I want to also thank Dr. Kanana. I see her online, the lead surge from the country here, from the government side, for all the support, for all the hard work you've been doing. And to my colleague, Dr. Henry, who is the surge coordinator here, thank you for all the work you're doing and for the effective management of the surge capacity so far that we have. So yeah, please enjoy the webinar, and I hope we'll make it more interactive and ask questions so that we can learn more as we move on in this journey of health, responding effectively to health emergencies in Africa. So over to you, Henry. Thank you.
Thank you very much again, Dr. Martins, for that wonderful welcome remarks. So without wasting time, we are going to delve straight into the substance and the presentation for the day, which is mainstreaming mental health and psychosocial support in responding to public health emergencies. And here with us, we have Ms. Stella Waringi, who is the expert on mental health and psychosocial support and the head of substance use in one of the counties, Nairobi County in Kenya. She was one of those participants who was trained on AVOC Surge as part of the AVOC Surge flagship in Kenya. She was also deployed during the most recent flooding event in Kenya for response. She'll be sharing her experience with regards to mental health and psychosocial support from the point of view of the affected population, and also from the responders, as we all know that WHO has documented from series of reviews that we can have mental health and psychosocial problem up to 2% of the population over 10 years that have been affected by acute emergencies such as conflict, wars, and all of that. So please, let's welcome Ms. Stella as she gives us the presentation. Basically what has happened, how they were able to respond and provide mental health and psychosocial support to the affected population, and the type of mental health issues that we will likely see during emergencies. Thank you very much. Dr. Stella, you're welcome for the presentation.
Thank you so much, Henry, Dr. Linus, and the whole team and the entire team. I just want to say good morning, good afternoon, or good evening, or depending on where you're joining us. And it's a pleasure that you took time to join in this webinar. As Henry have said, I'm Stella Warenge from Nairobi, Kenya. I'm a mental health expert with experience in mental health and psychosocial support in responding to disaster. However, I just want to appreciate WHO because I have more than 10 years experience in disaster response. And previously, you find like we are fighting for the space of mental health and psychosocial support to be incorporated in emergency response. But with the training, WHO coming in, training our team, and also making it a priority, we're hoping that this is going to be other countries, we're going to impact, and it has an impact on the other countries, how we respond to disasters and how we give it a priority. And not just as a response, it's a call for us as responders because we have documented impact. When you respond to disaster as a responder, as a fast responder, the impact it has. And we have had some of, as a country, we have had scenarios where we have recorded even cases of suicide among responders who would not be able to handle cases or the impact what they went through during a response. So welcome, and 2 points as we go through this presentation is I always say you reflect on yourself as a responder, and you never know when you're going to be an affected population. And again, I know we have people who have joined us who are managers. It's a time to do soul searching and introspectively ask yourself, are you making mental health and psychosocial support as a priority if you're seated in an office and you're making decisions in terms of public health in response to public health emergencies? Because it calls for you to start from the planning, the response, and even after care in the recovery phase. So it's two-pronged. We're going to ask, how can we become better in response? And also, how can we take care of our mental health as responders? We say, even a broken crayon still colors. So how are we going to continue coloring in every response? We are countries, WHO African region, which are prone to different emergencies. Most of us who have joined it are dealing with one public health emergency or the other. The Nigeria, and we have these emergencies cutting across the choleras, the measles. As a country, we have had to deal with floods. Some of you are in humanitarian crisis, for example, the Democratic Republic of Congo. I mean, and I believe each and every one of us would talk about a disaster that has a public health impact. So we just want to ask, what is mental health and psychosocial support? And just to bring to your attention, it's two of them, the mental health aspect and the psychosocial support. And in this webinar, I will just want to put more emphasis on the second part of it, the psychosocial support. Why? Because the mental health part of it is going to be built on how well we're going to receive the psychosocial support. And when it comes to mental health, you may say, yeah, let's leave it to the specialist. But I just want to give you a burden of being there to provide psychosocial support, because we're saying this is a type of support that aims at to protect and promote the mental well-being and to prevent mental disorder. So before they become a mental health challenge, how are we going to support the communities? How are we going to support the affected population so that when these public health emergencies happen, they don't develop mental disorders? And those ones who have a mental health disorder, they do not exacerbate. So how do we make sure we take care of this population? So it's a whole process, the psychosocial support. There's a psychological part of it, which deals with the emotions and the behavior. But there's also the social part of it, which each and every one of us, you don't need to be a counselor, you don't need to be a psychologist, you don't need to be a mental health expert, whichever domain or RLT member you are, whether you're seated in an office and you're the one who makes decisions on the budget to be allocated, whether you're the person who is doing labs and you're doing all contact tracing, the social support, we all have a responsibility. How you communicate to the responders as you do contact tracing, as you draw the samples, how do you reassure them about the procedure you're going to take? And I'm going to borrow from lessons learned from COVID, because COVID was an equalizer in terms of the impact it had across the globe. How do you go to that household and you're telling them that you need to go for quarantine, we need to take sample? How do you provide for the immediate needs? So all that you're doing in whichever capacity, we're just facilitating resilience among these individual, among this family, and even the community, because some disaster happen and they disrupt a community. Be it, for example, floods, there's displacement, the social values and the connectedness of a population is affected. So how do you do this when you're also maintaining and restoring dignity among this population? You're enhancing their coping mechanism. Remember, before this disaster happened or the public health emergency happens, this population had their way of coping. But all of a sudden, things happen and they don't have the social connectedness. They're not able to have those meetings, or maybe it's at the village level. How do they, they used to go to cope by going to church. How are we able to enhance that? And also, how do you restore social cohesion and even in the infrastructure so that after we have dealt with the emergency, the community can be able to recover better? So why do we talk about the MHPSS, the mental health and psychosocial support in emergencies? And I want to draw in terms of even before the emergency happened, what is happening in this community, be it at the rural area, be it at the urban area, the peri-urban, what is happening globally? And studies have shown that about 1 billion people are already living with a mental disorder globally without a disaster. They're already having their own mental and psychological concerns. Then we talk about when it comes to humanitarian emergencies, we're talking about almost all of them. Any person who is touched by a humanitarian emergency will develop a psychological distress. However, as human beings, we are gracious enough and we have a bit of resilience. It will improve over time, be it a stressful, be it anxiety, it may improve. But to about 22% of the population that is affected, they will have any mental disorder, depending with different severity, whether it's moderate, whether it's severe, and any of the mental health condition that we may deal. 22%. So when you look at 22% of the population, this is a number that we cannot ignore. And then you're talking about 9% of this population will have a moderate and severe mental disorder. What does this mean? This means that this 9% may need a more specialized mental health services. They maybe need to be seen by a psychiatrist, they may need to go for therapy, they may need medication. So this is a number that we need to be very cautious as we are doing our planning and even as we're doing our response. And then we're saying that the people who already have a pre-existing severe mental disorder are more vulnerable during emergencies, and they may need more mental health care and even basic needs. This is someone who is maybe struggling with schizophrenia, they're on medication, they have already lost some of the functionality. Then a disaster happened. Some of them have lost their cognition, they're not able to, how are we, then a disaster happened, there's displacement. They need more support because we have seen that even in a normal running of a society or in the community, people with already severe mental disorder, they have less 10 to 20 years, they will die early, 10 to 20 years earlier than the normal population. So a disaster or a public health emergency is only going to make this one earlier. It is going to make this one more worse. So having these numbers, and we say numbers don't lie, is going to make us reflect and be more intentional when it comes to mental health and psychosocial support in public health emergencies. So why do we need to provide psychosocial support? And I've already alluded to that. With this, we want to mobilize adequate social support to prevent distress and even suffer from more. But how can we mobilize if we are not planned for it? And I keep on hammering on that. The need to plan to make a community resilient. I mean, we are in Africa, more prone to disasters. We know we may be hit by a flood when the rains come. We know we may get an outbreak of measles, be it cholera, waterborne diseases. How do we prepare our community to be more resilient to this so that we avoid having more severe mental illness? The worst case with severe mental illnesses, they are more expensive to treat, they are more debilitating, they need more resources to treat, they may need to go to a higher level of facility. So how do we avoid that? Then we need them to recover better in terms of, and I say again, when another disaster happen or an emergency happen, how do they cope better? How do they recover better? How do they make sure that they're able to go back to normalcy better? And then how do we restore their social connectedness and cohesion? As human beings, we thrive in our social connectedness, and in emergency that is broken. How do we ensure that they're able to restore that? Because we build our resilience. Part of the major source of our resilience is in our social connectedness, be it in the family unit, be it at the community, and a community may be a church for those ones who are Christian, the Muslims. We have those connectedness, be it in the school where it becomes a safe space for children who are going through emergency. So how do we build that? So with that, I want just to share, as Henry said, that I'm one of the AVOC Search for Kenyan team, specializing in mental health and psychosocial support in emergencies. And one of the cases, on top of the others, as a country that we have gone through, we have had cholera, we had cases of measles, but in the recent, the few months or a few weeks ago or a month, is that we had heavy rains in the country. And with that, it brought flooding, and we experienced this to about 41 counties. In Kenya, we have 47 counties, what maybe some countries would call provinces. And in the highlight of these, the flooding, the displacement, one of the emergencies that really stood out for us as a country is what happened to us in a place called Maimahio. And why are we saying this? Because in other parts where we had flooding and people had an opportunity to move out, or they had an opportunity to be rescued, or yes, we lost life, but it's not in the magnitude of Maimahio, is how it happened. So what happened is that there were flash floods that happened on a high ground, a dam that burst and went downstream, spanning to more than 15 kilometers. And with the magnitude, we had homes being misplaced, families, lives lost, more than about 43 lives were lost. And in a span of 2 hours, the whole village or the whole community were turned upside down. So let's look at some of these pictures that we did when we responded. And just to give you a glimpse of it, is that the first picture is one of the ladies when the WHO team came to the ground to document the story. And the stories were heartbreaking. Let me just give that one of the first lady who is appearing on the picture. This is a lady who had a life going on. She had 5 acres of land. She had 2 sons, and she had crops in the field and chicken in the household, and she was having a normal life. But at 3 a.m., when the floods happened, she lost everything. She was lucky she didn't lose her life or one of the family, but she lost everything. And coming from us Africans, we are very much attached to property and land. And now she's here seated in a camp. And as you can see in that photo, she only has a bag and a mattress where she sleeps. Nothing else to her name. And it was heartbreaking when she says that the clothes that I'm wearing, even the inner ones, are borrowed. I was given. I have nothing to call my own. And the same story about the second lady who has 6 children and she lost everything. And as you can see in the third one on the left, is that this is where they are staying. And these are families who had normal lives, because where it happened is an agricultural place, but more than 150 families being displaced. And all of a sudden, you're put in a camp. What happens to you as an individual? Your dignity is lost. Your point of what do you own? Privacy. There's no privacy. The family, what you call your family, everything is lost. So this one brings a lot of impact on the psychosocial well-being of this population. So these are glimpses of what happened to us. And I'm sure even back in our countries, we are able to talk about these scenarios repeat themselves in the camps, be it in the internally displaced camp, be it when there is war. And we have seen this happening over and over. So just what happened is that we had floods happening in Mai Mahiu. And as you can see, we had much damage to the environment itself, loss of property and loss of lives. Then within 2-3 hours, because it happened around 3 a.m. and you can imagine when you're swiped out of your house at 3 a.m., you're sleeping and you had plans for tomorrow, and you wake up and you find yourself 5 kilometers and you're in the middle of water. Then we had multi-agency response, and our public health emergency coordination was activated, and we had a multi-agency response both from the national government, the county government, and the humanitarian response. And one of the things that happened with the activation of the public health emergency unit is that we had the RLT were commissioned and were comprised, and one of them, what we don't see every day as a country is that for this, we are so used to having rapid response team comprising of the disease surveillance, the lab, the IPC, the IPC, what we know as the RLT. But what was sad and broke my heart is that we had to have pathologists in this team. It may happen, but it's not your daily kind of response. And why? Because we had bodies that were lying in the mortuary that need to be identified. They were doing identification. And that was a different twist of experience. Despite having 10 years of experience, that was a different twist that we had in these. And then we had the coordination of mental health and psychosocial support, and with the other services that were going on at the site. So what we do as a team in mental health and psychosocial support team, when we went on the ground on this within 72 hours, and we all know in emergencies, everyone is a responder. And we usually say the first response is from the community. There's a lot of confusion. There are no mechanisms, no reporting. I mean, that's what happened in these 72 hours, because the priority is the saving lives, saving property, and there's a lot of cohesion and them coming together for the community. So when we went on the ground, is one of the things, I was leading the team, we had to identify who are the partners on the ground, and with that we developed the 4W matrix: who is where, doing what, and when. Because we have had instances where in the response a partner will come, bring 4 psychologists, and they withdraw them at their own will. So we had to assess who is there. It's not an easy thing, but it was a process that we had to do to understand what capacities are we having on the ground. And then we had to identify what are the urgent needs and gaps in this response in terms of mental health. What is it? As much as we have come in, we are professionals, we have a team, there's team on the ground. What is it that this community needs? In us, in mental health, some of the urgent thing is the basic needs. Basic need as much as food, some of things. And for us here, you found that an urgent need was as information. We want to know what information. When you give this person information on what is expected, how long they're going to stay in the camp, they're able to cool down, they're able to you reassure them, they're able to relax. We are just looking at their mental well-being. Then we had to identify the areas that needed support. Remember, we had in the response, we had people who were in a camp, and this camp was a school. We had people who had been injured, they're in hospital. We had families who were trying to identify their loved one in the mortuary. And we had people who did not come to the camp, but stayed at the community, or at the community, who are just touched by this emergency. They witnessed, but they didn't come to they weren't affected directly, but indirectly. Then the other thing is that to develop a duty rota, with deployments being done we establish a mental health and psychosocial support desk on site, and every morning we had to have a debriefing meeting and deploy from the desk so that we know who is at the mortuary, who is staying at the camp, who is going to the community, and is going to go to the hospital to offer support. Out of these kind of planning and coordination, we were able to identify one of the needs that is not usually, it doesn't come in immediately in most 72 or 1 week of disaster, is that we needed support with consultant psychiatrists. Why? Because we had community members who had already a pre-existing mental health condition, but they had a flare-up. You know, we had people who had psychotic features and we needed them to be seen by a psychiatrist. So I believe with these, we all gone through, we are responders or we have a role to play in response. And I just want to us to reflect whether you have taken part in a public health emergency response, whether you have been in a community level and you have been affected, and just you as an individual level or other community, what have you encountered and what are some of the challenges that you have encountered in terms of mental health and psychosocial support as an individual, as a community, when you're doing response or even after a response? So I want us to, we will use slido.com. We're going to have a poll. I'm going to request that we all go to Slido and we are going to just give this feedback in terms of what have been our experiences. Just be honest, we're not going to put up your names. We just want to see from the different country, I'm sure we have different ways, strengths, capacities. Here is a scan. You can scan the slido.com, the QR code, or you can even go to slido.com. And I just want to see what has been your challenges, or as you plan, do you even plan for mental health and psychosocial support response? So I'm waiting for your response. Let's scan the QR code, it's on the screen, or we can go to slido.com. So let's see what are the common mental health and psychosocial challenges in your different countries or counties, or even those of us who are working in the humanitarian organizations. Okay, I'm waiting for your response. Yeah, I can see a lot of anxiety. Yeah, and this is one of the challenges, psychological concern. People are anxious. Lack of mental health specialists or inadequate mental health specialists. Yeah, that is a major challenge, so that you find that you don't have specialists. But I also want to say in mental health and psychosocial support, sometimes the mental health as a specialist come at a very higher tier, at the top level. So it could be a challenge, yes, but it comes at the very top. And that is why we are seated here to say, what is your role in offering psychosocial support? But yes, if you don't have a specialist to be able to help you design mental health intervention, could be a challenge. Let's see. There's a lot of panic. I agree with that. You don't know what is going to happen. And let's borrow from COVID. You don't know, you're being told what would happen if you get COVID, you're going to be quarantined. Logistic shortage. Yeah, we always have challenges in terms of logistics, whether could be issues of transport, issues of reimbursement, issues of availability of the personnel, and how is that coordination going to happen? Let's keep them coming through. We are doing our own evaluation to see how alive we are to the someone has decided to do. Okay, let them see. Burnout and fatigue from constant travel. Yeah, and this is where we are also going to focus in terms of caring for the carer as a responder, you're more likely to get burnout. How do you deal with it? When is it that you know you need to take a break? Wow, they're coming in, they can fast. Community, some of them are broken, issues of anger. Some of them have broken down. Fear of unexpected, so it brings it about a lot of anxiety. Cooperation, there's panic, there's anger, and we have seen this happening when you're not coordinating and people become angry among themselves. Let me go to the chat. Some people, lack of transportation and poor quality of health service delivery. And we always say in public health emergency, when they happen and already the existing public health structures are compromised, it only become worse, where you have to travel for long distance in the normal before emergency to seek services when you don't have good coordination. And then when an emergency happens, it can only make the situation worse. Kindly use Slido. You're being advised to use Slido so that we are able to see the response in one. Lack of trust to information given. And I cannot emphasize this. One of the scenarios or one of the challenges we had in my Mahio is about the information. One, there's a lot of misinformation. And the other thing is that they're not trusting what they're being told. People come with different theories, what happened. And I think just to emphasize in terms of information, what we encountered is some people were saying that when the floods happened, the ground opened and some houses were swallowed in. So if you're looking for your loved one, you're told maybe they could have, all those kind of information. When the government officials come and tell you that you're going to be compensated, they may not be trusting that. So I think we've seen, thank you so much for your response. And there have been very good response. Thank you so much. And we cannot overemphasize. And I appreciate that you are alive to these kind of challenges that we go through. Just to emphasize, one of the things that one of the challenges is the aspect of what is the impact of any public health emergency. One of it is we have loss of life and loss of property. So one of the mental health or psychosocial concern we deal with is grief, because people have lost. So when they are lost, we have a lot of grief. The other one is that remember this population, and I'll say again, is that they may have gone through the same disaster. Borrowing from what we dealt with in Naivasha, it was a flash flood. One of the families we dealt with had gone through the same years back because there's a dam that had busted in kilometers away and they had been affected. This man had lost a wife and 4 children in that disaster. Years later, he marries, and now the same kind of disaster happens and he loses the wife and 2 children. So you can imagine his grief is not going to be normal. He's going to have a very complicated grief. And again, aspect of people with pre-existing mental health condition. Thank you so much. So what are some of the mental health interventions and psychosocial support intervention? At the top or at the list that we are able to do, which doesn't call you to be a mental health specialist, is psychological first aid. And this is what you give at that time when you meet this person who has gone through the public health emergency, who is in distress. How do you calm them down? How do you get to identify their needs? How do you link them to where there is more support? You have this mother and there's a building or there's a flood that has happened. They were able to save themselves. They don't know where their children are. How do you direct them where there's a linkage desk? How do you issues of gender-based violence happening? How do you link them to other social support? Then you can also offer group or one-on-one psychotherapy. This is where it needs now the mental health specialist to come on board. In Naivasha or Maimahiu, we were able to be lucky to offer one of the therapies that is usually forgotten in response. We always forget about the children, and we always say they are fed, they have a shelter, but we forget that they're able to process the distress, and most of them will exhibit it in different way. For example, bedwetting, clinging to an adult, staying alone. So one of the intervention that we're able to provide is play therapy. and we were able to use sports, use art for them to be able to express themselves. We had psychiatric review, and as I said, this is at the top tier, where it's for the few who have severe mental illnesses. Yeah, we are Africans and we are very religious, and we are not able to separate pastoral care. So we had pastors from different churches who have organized themselves and were able to come and do pastoral care. However, I would also want to emphasize that when you're doing mental health and psychosocial support in emergencies, you have to really give the pastoral aspect a specific time, because remember, the population is already vulnerable. You don't want to feed them on false hope. So what you do is you have to work very well with the people who are giving pastoral care and allocate them. Are you coming in at 3 to 4 p.m.? Where is it going to be done? And then you announce to the population when you're going to have pastors coming in at this time. This is where you're going to meet. So if you're willing to receive pastoral care, this is where it's going to happen. Then lastly, we had linkage, referral and linkage to other services. Those ones who needed to be seen by the medical team, who needed social services, sources of information, we were able to refer them to the team. So what are some of the challenges that we encountered from that experience? Is the poor coordination from the onset of disaster, which sometimes happen, no matter how sometimes well prepared you are, because everyone want to come in, everyone want to rush in. Then we had lack of reporting tool. As a country, we are yet to develop, and I'm sure maybe it could be the case in other countries or regions, develop standardized reporting tools for mental health and psychosocial support. Then inconsistent reporting within the teams. You have a team from this humanitarian response, they are reporting their numbers, another one is reporting. So those are some, so you find that there's double reporting, different numbers being given or different scenario. And then the other aspect is from the private organization before we put structures in place. Someone will come in, today they'll give 5 responders, tomorrow they give 2, some of them want to come at 11. So there's that also kind of inconsistent response from the private organization. We had a challenge in terms of lack of standardized or terms of reference for the responders. What do you mean when you say you have given group therapy? What does it qualify? So we didn't have common terms of reference among the respondents, and that one is a challenge to us, that we develop that as a country so that it can be used across, and then we do adaptation with a different disaster. Then organization withdrawing their responders at will. So this one breaks your team. You don't have a constant team at a go. So what are some of the lessons learned? One of the major lessons is that we need to have mental health and psychosocial support response plan, and not as an afterthought. As we are having contingency plans, we are planning for any disaster, mental health need to be included, and not just waiting for the communities to come out on screen and say we are stressed or we see abnormal behavior so that we respond. The other thing is that countries need to build capacities of their responders in how to offer mental health and psychosocial support. And one of the capacities is in terms of a simple intervention like psychological first aid. Whether you're a search and rescue team, you need to be equipped with those skills. Whether you're the medical team, as you're treating that person with a burn or with a broken limb, how are you able to offer psychological first aid to them, including the communities, so that they can be able to respond better, not just pulling you out from the, or for example, from the flooded water, but are they able to support you better? Then develop a referral and linkage for specialized mental health care. So we need to have a referral pathway of care for those people who have gone through, have suffered, in terms of during the time and even after, how we able to have follow-up. And that ties with the next point. How do we ensure that even if you're seen during the response, how are we able to have an aftercare plan? And then I cannot overemphasize the support of the leadership in executing MHBSS response, more so in recovery. There's a lot of support during response sometimes, it could be there, but the gap comes in recovery. And if we look at the case in Naivasha, where schools were opening after that, and you find in a class, maybe they have lost 3 children. What about those other children who their colleague is not reporting because they died in the disaster? What about that teacher? What about that community person, community leader who we lost in the response? So yeah, so those are some of the lessons learned. I want us again, this is mental health. I want us to reflect. Even as responders, we have own challenges at individual levels. We are dealing with families, we are dealing with work, we are dealing with the different things in our lives. And I want to ask ourselves, this is, we call it a screening tool. It has been validated to be used among respondents. And I want just to put in the chat, this one we're going to do in the chat. How are you feeling today? Just click the number of the ship on the chat. I'll be able to check on the shop on the chat, sorry. And why are you feeling that? Just a minute and reflect. Have you had a bad day? Are you going through things in your life? And how does it make you feel today? So this is internal reflection. How are you feeling today? I will not mention your name. I will just read the chat, what you're feeling. So let's go to the chat and just mention the ship, and maybe you can say why. Are you feeling a 9? Are you a 3? You don't even know. You don't want to wake up. You just want to pull the blanket and sleep. Are you a 4 and it's all dark and you're in a dark space? Or are you a 8 and you're getting out of where you have been through a lot and you're figuring out what is next? Let's see from the chat. Someone say they are a 7. Let's use the chat to see, just to check on where we are. So you're hiding there. You need to go, but you're taking a step back to re-strategize. Oh, we have a 2, we have a 7, we have a 2. Oh, you're all feeling all happy or relaxed. That is nice to feel that with people who are just feeling relaxed and enjoying the breeze with a 2. We have a 9. Oh, and this is so exciting that we have people who are all jubilated, you're happy, you're enjoying the lash of the life at a point in your life where you're just feeling like, yeah, it's never that serious. I can have a me time and I can enjoy myself, and I want to have my id, the child part of you kick in and enjoy the moment. Thank you so much. We have a 5. Oh, sorry. Whatever you're going through, you're a 5. You want to bury yourself. There is help for you. Just reflect and acknowledge, what is it that you're doing? Is it something you can change now? Is it something you can seek help? Or is it something that you just want to avoid? We always say that whatever it is that you're going through, that it costs your mental well-being, it is not worth. Thank you so much for your honest responses. And lastly, we have an 8. Sorry. Ooh, you want to breathe, take a breather. Thank you so much for agreeing. I'm sad we don't have a 6 who is feeling flowery and all that, and we don't have a 3. So it means we somehow take care of our mental wellness and we don't get all drowned. Thank you so much. Yeah, someone is saying they are too. Yeah, thank you. And I believe that I want to take this just to do an analysis with the high validity and reliability of this tool, to say that as members, at least we are able to have an honest inventory of where we are. This is very good. So as responders, mental health and psychosocial support is very key. We are able to recognize what are the signs and symptoms of distress or stress among the individual and even at the organization level. Are we sending one team to respond for something that is taking 3-4 weeks? How are we arranging the duties? So are we able to recognize? Someone talked about one of the effect being anger. Are we able to realize that the team member, there is no longer teamwork? People are more angry on a very small thing and they become irritable. So response to stress is influenced by different level, the severity of the impact. You may respond to one thing, cholera, in a small scale, and you may respond to a bigger scale where we have loss of life, we have and even how it happens, and the scenes are not very good at individual and even organization factors, where we are talking about lack of logistic at organization level, lack of compensation. And the smallest thing is in terms of recognition. Are you recognizing the responders? Then common challenges among responders, we talked about burnout and even stress, and it's a role. And I always tell people or respondents. As much as we have challenges at the organization level, let's take self-care as a personal thing. Irrespective of how good organization is, what are you doing at a personal level to take care of your mental well-being? So how do we cope and build resilience among respondents? Just be aware of the triggers. And I believe, having been trained as an AVOC surge responder, to those ones who have been trained, you're told to evaluate what is it that you can respond. Myself, even being a mental health expert, there are some of the emergencies or disasters I'm not able to deal with, and I've come to terms with. I'm not able to respond or to be on the first line where kids are involved because it hits me deeper. Are you able to evaluate yourself and see what you can deal with? Are you able to evaluate yourself and say, these are my strengths, these are my weaknesses? Are you able to build on your social support? When you come from the response, who is your social support? When you go home, how is our relationship is at the family level, at the community level? And you would attest to it what happened with COVID. Some of us were in the first line of response. In our community, we were being ostracized. We were not welcome because we were being told we are the one to build, to bring COVID back to the community, at the family. So how are we going to build a social support of people who understand what we do, who understand you can go home this day and your spouse is able to say, how was your day? You look like you had a long day. Do you need time alone? What can I do to make it better for you? Who are the people we are responding with? Are you able to have a debrief and sit and say, I felt bad looking at that child who had decapitated and all that. It made me reflect on my own children. It hit me hard. Looking, are we able to have those conversations as group? And then who is it that you can count on? You can call them and say, I'm feeling bad today. And then how are we building new habits in the heat of a response? We are more likely to work long hours, not sometimes because we are called to, but it becomes a coping mechanism. How are we able to make sure that we maintain routines like physical activity, drinking water, having a diet? And I believe if you went through AVOC, how do you plan better to make sure that if you're an emergency responder like some of us, we have bags that are usually packed. We have, camel packs because I know I need water when I go to response. How is it that you're able to make sure that I'm able to do physical activity? I'm able to reflect in the evening. Then how do you manage to your emotions and even to relax? Doing an honest inventory. Today I went for a response. I felt not supported. I felt not appreciated. And then how do you relax from that? Do you take a walk? Do you listen to a nice music? Do you read a book? Do you take a drive? So that is your personal responsibility, just to make you better as you respond, better for yourself and even better for the community, and even preparing you to be more resilient in the next response. Not forgetting that sometimes we are responders, but there are times when we become the affected population. So in conclusion, I want to say that we need to treat mental health as a cross-cutting issue within the Ministry of Health, in the protection, in the nutrition, education, camp coordination, and camp management. How do we incorporate mental health and psychosocial support in health? I know most of the time is seen as a priority for health, but in education, we have the schools. How do we make a resilient population among these kids? How do we train them on how to do breathing exercise and support each other? We need to reflect mental health indicators in relevant planning documents. How many of you would say that you have mental health indicators, or even as simple as in your daily reports of an emergency? We have countries who are dealing with floods. We have countries who are dealing with cholera. How much of mental health indicators that are there? How many have budgets set aside for mental health response, and we are able to track? Then we need to support for creation of work of country level mental health and psychosocial support groups in migration, in refugee and humanitarian context. Do we have mental health and psychosocial support working group at a country level, at a region level? And how are they activated? How are they kept on top of things and incorporated in the other planning? So we need to provide services, basic at the community level to the clinical care. We say that mental health is not just about seeing a psychologist, it's about giving information, it's about psychosocial support, is about providing the basic need. Even if you have the best psychiatrist and this person doesn't have food, the food is a priority than being seen by a psychiatrist. We need mental health care needs to be made available immediately for specific urgent mental health problems as part of health response. Let's not send a medical team and we're not sending a mental health and social support team. Then in emergency, despite their tragic nature and bad effects on mental health, have shown opportunities to build sustainable mental health system for people in need. So let's keep on making our responses better. Let's keep on integrating mental health. And I wouldn't have done justice without saying that mental health, how well we structure mental health response, is going to be a driver on how well our intervention are received. For example, you're dealing with a population, and we have talked about 22% of the population having pre-existing mental health intervention. But you want to talk about, you're doing a response, what I would have on top of my mind, for example, cholera, and you're talking about hygiene, food hygiene, hand washing. And this population, for example, it's community, maybe they're having these families dealing with depression. They're not going to take the messages as seriously. So how good how well their mental wellness is going to improve the outcomes of other interventions we are going to have as we respond to public health emergencies. Thank you so much. I know it has been about an hour. I want to thank you for listening in and also give it back to Dr. Henry, to take us through any question and answer plenary session. Thank you. Henry, your mic is muted.
Thank you very much, Stella, for that wonderful presentation. That was well delivered. And the important points have also been made that about 22% of the population in emergencies actually experience some form of mental health and psychosocial issues, out of which about 9 of them are moderate to severe. So if that is the case, how do we plan differently? How do we respond differently to make sure that this critical mass of victims of public health emergencies are not left out in our response? As we know that most times we plan for every other thing, but we don't plan for the mental health of the victims. We don't also plan for the mental health and psychosocial support for the responders themselves. So this is more like a wake-up call to do our response differently, right from the planning stage, even down to the delivery of interventions to the affected population. So because our time is fast spent, we want to quickly give room for a few question and answer session. If there are contributions or questions, we'll be happy to just use a few minutes to take it. From the Q&A session, I haven't seen much. We've seen someone asking for the slides, which we've said the slides will be shared. The recordings also will be shared, and there's a repository on YouTube where you can go and see all the presentations that have been made previously. So that will be shared. And someone has also asked whether we can have translation in French. Unfortunately, we are not able to do that for this section. However, maybe in the future, if we're able to, we'll also communicate it along. So these are what we've seen in the Q&A chat, in the Q&A session. So I don't know, maybe we'll just give a room for 1 or 2 persons who would want to either make comments or ask questions directly before we close. Any clarification on any area? So we haven't seen. Okay. So it looks like I haven't seen any hands raised. That means that the presentation was well delivered. There are no questions or contributions. So once again, I want to thank Dr. Stella for that wonderful presentation. It came with a lot of information. At some point, I almost started feeling that I was also being cancelled. I started feeling the impact of the psychological first aid. And also very important that when we all go out to respond, and we've seen a population which we know definitely that about 5% of them are already into very severe psychological problems. There is something we can also do. We can also provide some level of psychological support, psychological first aid to them. We shouldn't be all about just dishing out the interventions that we've come with. We should be able to give some level of psychological first aid, and if need be, we can refer them, assuming we did not ab initio plan it, to have certified mental health experts and psychosocial support experts within our team. So thank you very much. I have seen one hand raised. Let me see.
It's me who had raised the hand, Henry.
Okay.
There's can I go ahead? There's a question. Someone is on the chat. Someone is asking, in my country, is social workers recognized to offer mental health and psychosocial support? Yes, they are. It's only that the level. As a country, we have recognized, we have formed mental health, what we call now, we have a mental health act who recognizes who is a mental health professional. And this is 5 cadre: psychiatry, psychology, psychiatric nurse, and a cadre called psychiatric clinical officer. Whereas social workers are not mental health practitioners, when it comes to psychosocial support, in terms of doing debrief, low intensity psychotherapy, they are recognized to do that. Yeah, so, and maybe Henry, there are some more questions that came in.
Yeah, I can see more
yeah.
questions, mainly on the chat room. I was looking at the Q&A session before. What effort is WHO making to improve MPHSS in emergencies in Africa? I would talk about just in a nutshell. In a number of emergencies, for instance, I'll use Nigeria as an example. During the COVID, there were people who were engaged primarily to offer mental health and psychosocial support. And in the Northeast also, we also had some experts who were dedicated to mental health and psychosocial support, which we think that going forward in most public health emergencies, there should be a provision for an officer who will dedicate his time for mental health and psychosocial support. At some point too, even within offices, there were schedules for people, experts to come in to the office and have some sessions with responders to know how they are feeling. And then from there, they'll be able to see who among the officers in the field requires more detailed interactions with mental health officers, or those ones are needed to be pulled back for either to rest and recuperate or get some improve their coping mechanism. So can we have responders trained in first line in future to be able to help victims during response to public health emergencies? I think, Stella, you can answer this.
Yeah, I think unless it's the AVOC team, the respondents, and that is why I started off by saying that I really appreciate when the AVOC such training came on board the APR, is that we have mental health being at the core of the training. However, I know it may not reach 100%. So I think this is a clarion call. I don't know if we can do it two-way, where maybe WHO could have, because a PFA would take training for about 2 hours, do a sensitization. However, the country level, I would encourage them to do those trainings at the country level in terms of either online to reduce on the resources, because psychological first aid is a basic training and you need it as a responder. And I said, whether you're a lab, whether you're an epidemiologist, So maybe would request WHO if they would provide resources to even run online courses, online or virtual, but also at the country level. Thank you.
Thank you very much, Stella, for that wonderful response. I think at this point, I see there were more of comments than questions. One said, well said. For us too, by the time she put up the ship feelings, we had already undergone some form of counseling and had reached the stage of relaxation. Many thanks for putting together this session, Kenya. So since we don't have many more questions and our time is also due, we are unfortunately 8 minutes past the time. So I think it's a good time to really adjourn this section. We sincerely want to thank everyone, the WHO Hub, who have the IT session, who have made sure that we had a hitch-free session. Thank you, the presenter, Stella, for the wonderful presentation. To the Ministry of Health Kenya for the opportunity to present this, and then also to WHO Kenya for the coordination of these wonderful sessions. And for all the participants that joined from different countries, from Nigeria, Ethiopia, I can see Tanzania, I can see, of course, a number of people from Kenya, and
Sorry,
so many other countries.
Harry, there is a hand I'm seeing. I don't know that the person has asked that question.
Okay, I don't know. Is there? Okay, so there's a hand that is raised. Annelise Doom.
No,
Okay, maybe
Henry,
we
thank
can
you for the
take it quickly.
opportunity.
Yes. Please go ahead.
No, I just, do you hear me?
Yes, we can hear you loud and clear.
Okay. No, I just wanted to comment on the remark that Stella made that in Kenya, the responders, the first responders in terms of mental health and psychosocial support is the psychiatrists and psychologists and those nurses. But in our country, it is the social workers. We are the frontline runners in terms of all these things that she talked about. And then when we need more in-depth care, we will do then referrals to our psychiatrists and psychologists and the other healthcare practitioners in terms of this. That was just my 5 cents that I wanted to throw in. Thank you so much.
Thank you very much for that wonderful input. We also do recognize that the scenario might be different in different countries. There are also places where the MH gap training is well entrenched within the country, and they offer a lot of services even at the community level. So understanding that there are different levels of training and different peculiarities for each country, the emphasis is just to make the best use of the structure that we have within the country to give to the best to the communities and the victims of public health emergencies, and also to the responders as well. So thank you very much. I don't think I can see any other hand. So I want to once more thank everybody for this great opportunity to learn, to share experiences, and to relearn what we have done, hoping that with this consciousness, we'll better plan to mainstream mental health and psychosocial support in all our public health emergency response. Thank you very much. Until we see again during the next monthly webinar series. So please, as was emphasized before, do give us your feedbacks when the surveys are sent so that we can improve on subsequent ones.